So what I'm going to talk to you about, I do have some PowerPoint, but it doesn't matter if it doesn't appear, is, well, first of all, I want to start by acknowledging the traditional owners of this land, Aboriginal elders. And when we make those sorts of acknowledgements to land and country, especially when you're talking about health issues, it's really important to remember that still today Aboriginal people have a decade or so difference in life expectancy. And so it's a really important issue that has a real meaning. But I'm talking about, I'll talk to closer to the microphone. I'm going to talk to you a bit about the health system of the future and some of the issues that we're facing in the health system of the future. One of the issues that people talk about is the so-called evil oldies, or the Silver Tsunami, that this wave of older people is going to overwhelm the health system in Australia. And it's as if it's a big surprise. Well, hello. If you've got a whole lot of older people today, you're going to have a whole lot of older people tomorrow as well, because not all of them die every night. So, you know, this tsunami, which is an overwhelming and a dramatic effect, is actually not what we should be thinking about. So the Silver Tsunami model is sort of a So this little cartoon says to this poor person fronting up for care, "I'm sorry, we're bombarded with aging boomers. Come back in about 20 years' time." And you have this conference, the Silver Tsunami. But really, what I'm going to argue is it's more like a grey glacier. It's a slow impact. So I just want to talk about some of those policy issues, talk about some facts, talk about some non-solutions. And so you have this argument that the health system is unsustainable, health spending is unsustainable, health costs are out of control. But first of all, I want to talk a bit about where Australia is internationally. And if you imagine a plane, a Cartesian plane, where we try and arrange all the countries of the world in terms of how good are they on potential years of life loss or life expectancy, and how good are they on cost per head of population in the health spending, and then think about the international average being in the middle. Some countries are above average in potential years of life loss, which means they're worse. Some countries are above average in cost per head of population, and so you've got a good quadrant and a bad quadrant, and you can array all the countries of the world along a diagram like that. And that's what I've done, and the OECD average is there in the middle. Way up on the top right-hand corner is the United States. Very, very expensive country, very, very poor life expectancy or whatever. Down the bottom there is Australia, in the best performing quadrant, just in the best performing quadrant, but still there in Canada, a country we often compare ourselves is there as well. So in fact, the Australian healthcare system is actually performing well internationally on those two measures. And they're not bad measures, life expectancy or potential years of life loss and spending. Now, the problem with graphs like that is this is an average. And there's considerable variation in the country. I'll skip that, but that's an example. But moving on, when we start talking about, so we start off by saying the health system is not bad internationally. Then we say, well, is it unsustainable? And here we have a little cartoon of a guy who's growing up, and the father said, but this endless growth is unsustainable. Well, what's the alternative? So here we have a graph. It doesn't matter what the axes are, but it's about health spending. You can see it going up and up, and it is going up and up. It's a projection into the future for the next 30 years, 20 years, and again, the graph is often and upwards. This graph is about spending by government, and it's Commonwealth and state spending. The width of the bars at the bottom there is how much government spent on these things in 2002-3, and the height of the bar is how much it increased as a percent over the next decade. And you can see that welfare payments on the right-hand side there, brick, broad base, that didn't increase as fast as gross domestic product increased. Then you have on the left-hand side the ones that increase faster than gross domestic product, and health is one of the ones that government spending on health increased faster than gross domestic product. Look over on the right-hand, extreme right-hand side, that's ageing. Actually a very small base, but a very rapid growth, but still not as big as people sometimes think. And if you break up the health spending, the big growth, this is the same sort of graph, but just breaking up health, the big growth is hospitals. Large amounts spent in 2002-3, very much great growth. And it's those sorts of graphs which are about increasing spending by governments that get people to think about the health spending is out of control. So, and then you have this next graph. This graph is about hospital use. And if you look at the bottom graph, for example, this is the use of hospitals per 1,000 population, admissions to hospitals per 1,000 population in 2001-02 for females. And you can see a sort of a standard curve there where people in their 80s and so on have much more hospital admissions than people in their 30s or 40s. But then if you go look at the graph above it, that's the graph of females in the female utilisation in 2011-12. So you can see that the big change is about increase in admissions of people in their 60s, 70s and 80s. And the same is true for males. And so it's that sort of graph that gets people to say, oh look, the oldies are overwhelming the health system. What we then did is say, well hang on, is that true? So we looked at the change in health expenditure that has occurred over the last decade or so, and for public hospitals, medical services, medications, private hospitals. The bottom dark red bit is how much of the change is attributable to population growth. The next orange bit is how much is attributable to ageing. The next sliver is health inflation, and the white bit is everything else. So in reality, ageing accounts for a very, very, very small bit of the total growth in health expenditure. And it's partly because there are fewer people, so the big change is everything else, which is about changing practices. There are more things we can do nowadays. There's more new drugs, more operations can be done and so on. So the big issue is the question is, should we think about the future in terms of this ageing sort of discourse or this ageing meme? And so people say, oh look, the population of people over 85 is going to double. You know, disaster is going to strike. Doom and gloom are the choices. But let's assume that people over 85 have 25% less illness compared to today. Because the reason they're living longer is they're healthier. So it's not unreasonable to say that someone in 10 years' time who's 85 is going to have less health needs than someone today who's 85. If you make that assumption, then the admission rate is actually only going to increase by 2/3. So the population over 85 doubled, but their admission rate only increases by 2/3. It's still an increase. Another way, so it's not quite as much doom and gloom. Another way of phrasing that is utilisation is projected to increase 2% per annum. 2%, coping with a 2% increase is much more within the bounds of possibility than a doubling. So that's why I call it a grey glacier, that it is a small change that we're talking about. But we still, does it mean that we can just sit on our laurels and fold our hands and say, yeah, don't have to worry about it? That's not what I'm saying. I'm saying that yes, there is an issue here, but it's an issue that we can cope with and we don't have to throw the baby out with the bathwater. So, a grey glacier. So, when people talk about this overwhelming population with the Silver Tsunami and so on, it's what I call voodoo demographics or apocalyptic demographics. And it's blaming the elderly for everything. And of course, it's demeaning to the elderly, is the first point. The second point, the elderly have all worked, they've all contributed to our society over the last 40 years. And hello, isn't it time that someone contributes to them sort of thing? So it's just ignoring the past contributions to the older people. It ignores their current contributions, you know, grandparents looking after kids and all that sort of thing, and what one author calls intergenerational interlinkages, that there is this exchange that's taking place within the family and so on. And also, as we know, increased life expectancy increases gross domestic product. So there's a whole lot of good things about an ageing society which we often forget about. So we spend a whole lot of money, and this little cartoon is about, the real issue is demand, not the changing demand patterns, the changing practice patterns, the things we can do. And the question is that driven by patients or is it driven by the health professionals? So do you blame the patients for getting old, or you say, well, hang on, who's actually driving this change? Now, I said also we're spending a whole lot of money. In fact, we're getting something for it. This graph is of what's called amenable mortality. And so the statisticians have divided up death rates into some things that are clearly preventable, some things which are able to be influenced by the healthcare system. And they've called those things amenable mortality. And what you see here is the rate of amenable mortality is actually going down over the last 20 years. So this investment in the health system is actually leading to benefits. And many people in this room, many people in society can actually attest to that they're now alive because of healthcare interventions. Similarly, when you ask people how healthy they are, fewer people are reporting that they're in poor or fair health. The heavy dark bit down the bottom is poor health, the next bit is fair health. So fewer people are reporting they're in poor and fair health. So both in terms of mortality rate and what people are saying, the healthcare system is actually doing good things. So what I call sustainability panic, panicking and waving your hands and saying, oh, it's all doom and gloom, often leads to panic type solutions, which are the wrong types of solutions. Skip that. So health spending is increasing. We're getting something in return. Should we sit down and do nothing? My answer is no. But you need small, careful changes. So here are some non-solutions. Shift costs onto consumers, and I'll show you why in a minute. Privatise everything in sight and reduce services. So why should we shift all the costs onto consumers? This graph arrays the wealthy countries on a graph in terms of what proportion of their health spending comes from public sources versus out-of-pockets versus private. Way up on the right-hand side is the United States. A significant proportion, half of its spending comes from private sources such as out-of-pocket costs or insurance. Australia is up the right-hand end of that graph. So our capacity to increase the amount of money we get consumers to pay is actually quite limited in terms of the international spectrum. And if you start to shift more onto consumers, then you're going to have equity issues. And this is just an example of that. It's looking at how much people spend out of their household income. And as you expect, wealthy families, wealthy households, the top fifth of the households spend much more per fortnight than low-income households. But as a proportion of spending, the low-income households are already spending 50% or so more than the high-income households, 7.5 or 7% versus 4.5 or 5%. I'll skip the privatising one. So, what do we need to actually do? Well, the first thing we need to do is reorient the system. The second thing we need is focus on efficiency, and third is eliminate waste. And what do I mean by reorient the system? If you think about the way the health system is organised, if you think about the health system, you think of the Royal Melbourne Hospital down the road. You think of a health provider, and that's not where we should start. We should start by thinking about the patients. And if you think about it, chronic illness is becoming more and more important. And one of the issues about chronic illness is the person with a chronic illness lives with it 24 hours a day, 7 days a week. So they are the people who understand what that illness means. So if you're going to try and reorient the system, you should be trying to orient the system so it looks after, does as much for that person, and to help that person to do things for themselves. So help them with self-management, help them with the skills they need to manage their condition, to monitor how they're feeling and so on. And here are this is a tale of two cards. On the left-hand side we have a Medicare card, and on the right-hand side we have a bank card. If you've got a bank card, you can go to an automatic teller machine anywhere in the world and get your money out of that teller machine. So how does that happen? You control the access to the information. Somehow or other the computers talk to each other. somehow or other the computer knows how much you have in your bank and allocates it back to you. So it's personally controlled, private, because you have that information, you've got the PIN and so on. On the left-hand side is the Medicare card, and all it's good for is to be a photo on the slide that I've got in front of me. That is, you can't use the Medicare card to get your personal information. It doesn't have your PIN on it. It doesn't have access all over Australia. It doesn't have your x-rays on it or anything like that. And why is it that the banks can do it and Medicare can't? So if we're serious about putting control back into patients, we need to actually be serious about changing all this. So then I said, okay, well, then you move outside the circle. So instead we start by trying to help the individual. Then you say, well, the next thing we do is try and help the family and the caregivers, and that is giving carer support and so on. And the next thing we do is say, only then do we start talking about the health professionals who come in. And so it might be the GP and other people who need to support people in the community. Then we start talking about specialists. So rather than thinking about the Royal Melbourne Hospital as the specialist centre of the world and so important and taking up so much of our money, they are the fourth on this set of slides. And then we start talking about community support to do all this, the wider society, and then the global influences such as climate change and so on. So all of this is linked, but it's got to start in the middle with the patient. So that's one story about reorienting the system, changing the priorities, changing the status and so on. The next thing we might talk about is, well, is all the money we're spending, is that worthwhile? Well, here's a couple of slides. Here, in the good old days, we had nice hospitals like the Royal Melbourne, and money fell from the sky into their grateful arms. We all thought that was a good thing. So this slide is about hip replacements, and it compares a hip replacement, a hip prosthesis called bionic, with all the others. And what you see here on the left-hand side is the likelihood that that prosthesis is going to fail and you're going to go back to hospital within a year. And on the right-hand side, the likelihood that it's going to fail and you're going back to hospital in 3 years. On the left-hand side, if you have a bionic hip, it will, that's a brand by the way, it will fail 3.5% of the time in the first year compared to all the others which only fail about 1.8% of the time. Bionic fails 6.5% of the time over a 3-year period. All the others fail about 3% of the time over a 3-year period. So this involved looking at all the hip replacements done in Australia, and obviously someone is choosing to put in bionic hips even though they fail at 2 or 3 times the rate of all the others. This is an example of waste. This is the sort of thing that needs to be addressed. Here's another example. These dots, every one of these dots represents a hospital in Australia. And what we did was we worked out how much it would cost to treat patients in that hospital. Then we standardised for the sort of patient that they treat. And you'll see that on the extreme left-hand side, there's one hospital that costs $4,000 per patient on average less than all the other hospitals, than the average hospital. And there's one hospital on the extreme right-hand side that is $8,000 more expensive. Huge variation in costs per patient treated in Australia. And here's another hip replacement example. These are 6 states. The top state, State A, the heavy black line is the median cost per hip replacement in that state, and the boxes represent 50% of all the hip replacements that are done in the state. You'll see that the top state, State A, the average hip replacement costs about $27,000. State F, the average hip replacement costs about $15,000. Huge variation between states in the cost of hip replacements. These are the top 7 hospitals in terms of the volume of hip replacements done in these hospitals. Hospital A, the average hip replacement is $2,000 or so per hip replacement. Hospital G, the average hip replacement costs $10,000 or so. A doubling of the average cost. And these are high volume hospitals. The other thing you can see is that, the box is much narrower in Hospital G than it is in Hospital A. That's because Hospital G is tightly managing how it manages the hip replacement. People go in, they have an operation on the first day or the second day, tightly managed. whereas in hospital A it looks like it's all over the place. So again, what we're saying is, yes, we're spending a lot of money, but there's a lot of money that can be saved without reducing services. And I'll just ask you a question. So the first question is, should you reward less efficient hospitals by paying them more for treating patients than more efficient hospitals? And in Victoria, that's what we did until the early 90s. And then we said, hello, that's a bit silly to actually pay less efficient hospitals more than efficient hospitals, so let's pay everybody the same. The next question is, should you reward poor quality by paying hospitals that have higher rates of adverse events than hospitals with lower rates? And that's what we do today. So if you go into hospital and they operate on the wrong leg and chop off your wrong leg, then we pay that hospital more. Well, no, that's a bad example. If you go into hospital and they leave a sponge in you after the operation, so you have to go back to theatre to have the sponge taken out, we pay that hospital more than the hospital where they didn't leave a sponge in you, because they paid for the sponge to be taken out. Now, is that a sensible set of incentives to put into the system? I'll just let you think about that. Here's some work that Grattan did on drug pricing. And this cartoon says, the drug is in the experimental stage. The pharmaceutical company is testing the price to charge for it. So we compared the cost that the pharmaceutical benefit scheme, the PBS, pays for drugs in Australia with the cost that the Western Australian government pays for Western Australian public hospitals, another state pays for public hospitals in that state, and New Zealand pays. On the extreme left-hand side, there is one drug that the Western Australian government pays for public hospitals in Western Australia, and the Australian Pharmaceutical Benefit Scheme pays 62 times as much for that drug as the Western Australian government does. The orange dots are New Zealand, and the black dots are the unnamed states. On average, across those 75 drugs or so, Australia, the PBS pays 8 times as much as New Zealand, the other state, or Western Australia. So we estimated there's $1.3 billion of savings every year if we just pay the same as those benchmark people. And I'll skip all that. So, where we go? Sustainability panic, which is what I started with. Oh, look, doom and gloom, the oldies are here. Versus doing this hard yards, the detailed analysis, collecting the data, working out what to do, comparing ourselves with people overseas, working out what is good practice. I believe that with those sorts of initiatives, we can make sure the health system is sustainable into the future and it's around. And that doesn't, so we've got a good health system now, we can make it better. Improvement means just that, improving the system, not throwing the baby out with the bathwater. Sensible change, sensibly implemented. Thank you very much.
Thank you, Stephen. Could I invite you to give some questions for Professor Duckett?
Just a quick question. When you were talking about the cost of hospital in one of your earlier slides, with governments changing their approach to mentally disabled, taking away some of the other accommodations that is required for some of those people, and putting them in hospitals, so that taking that that aspect in.
So the question was something along the lines that we're looking at comparison of hospital expenditure over a decade period. There's been a shift in practice patterns. The people who used to be in hospital, if you've got the question right, people who used to be in hospital now might be in nursing home, now might be looked after at home. Does that take all that into account? And the short answer is yes.
Even my papers of this morning, yesterday, full of Obamacare. Would you like to make a quick comment?
So the question was, the papers are full of Obamacare, would I like to make a comment about it? So, in one of my first slides I showed you that the United States health system has the worst outcomes of the OECD and is the most expensive. On current trends, that is assuming Obamacare is implemented, they will spend 18 or 19% of gross domestic product on healthcare in 2022. Australia currently spends 9%, they currently spend about 17%. So it's a very, very expensive system, the whole US system. One of the issues about the United States system is about 20% of the people don't have any coverage whatsoever. And so that has both consequences for individuals and consequences for hospitals and carers because they end up with bad debts. So what Obamacare did was try to address that. It doesn't actually end up with everybody still having health insurance, and the arrangements for Obamacare are totally different from Australia. Everybody still gets to choose and all that sort of thing. So they don't have anything like Medicare for the average person. They have Medicare for people over 65. But it's quite a complicated system, and it put an onus on states to do certain things. The Republicans, Obama being a Democrat, the Republicans were totally and completely opposed to it and fought it every inch of the way up to the US Supreme Court. From my perspective, Obamacare is actually an improvement on what they had before it, and it's actually going to, there is a claim that Obamacare will moderate healthcare cost growth. I'm not quite sure that's true, but healthcare cost growth has been increasing so rapidly anyway. I don't think it's going to increase the rate of growth. So it's actually not a bad system for where they started from. It's not where, but they can't end up anything like Canada or Australia or the United Kingdom. So I think Obamacare is good. I won't say it's as good as they can get, but it was a good compromise that they could get through the Congress. But as you see at the moment, it's one of the Republicans are trying to unwind it by shutting down the government. So it's a really interesting fight that's going on.
Why is the cholesterol lowering drug so much more expensive in Australia?
Why is the cholesterol lowering drug so much more expensive in Australia? Well, this was it's the subject of the Grattan report. It's I think the biggest selling drug in Australia. It goes under the brand name of Lipitor, or atorvastatin is the generic name, and it is, I think, 30 times more expensive in Australia than in New Zealand, from memory. And what New Zealand does is it goes to tender, and it says, you know, who wants to supply atorvastatin? Once it's gone off patent, so this is about off patent, it's no longer on patent. So New Zealand goes to tender, and they have one supplier. As it turns out, in New Zealand, the supplier is Lipitor. It's actually the generic. It's made by the same Pfizer. So Pfizer won the tender, and I think it's $2 for 90 tablets, whereas in Australia it's $30, 70 something for 30 tablets. Or, you know, is it 70 something for 30? Anyway, it's something like that. So whereas in Australia, rather than going to tender, they still say to the drug manufacturers, yeah, how much do you really want to pay? So basically they force the price to come down by 16% as soon as something comes off generic, whereas in Canada it's 80%, I think, 85% in 6 of the provinces. So a huge difference in the initial flag for reduction. And then they say, well, let's see what discounts you give to chemists over the next year or so, and we'll drop the price in line with those discounts you give to chemists. And it's a very slow process, and it ends up we're paying way, way, way too much. And I think it's because the price setting, the governance is all wrong in how we set the prices. They're not just being hard-headed and business-like in how they negotiate. Sorry, where was the next one?
In your view, to what extent has the fear of litigation pushed the cost of medical care upwards?
That's often, it's more used as a reason in the United States for their very high costs, and there's been a recent paper which suggests that even in the United States, defensive medicine, the question was, to what extent do I think that fear of litigation has pushed prices up, puts costs up?
In terms of over-investigation.
In terms of over-investigation, we're like, yeah. And so the evidence, the article in the United States, from the United States, said in the United States it hadn't had as much of an impact as people talked about. I haven't seen any research evidence on that question in Australia that I can think of at the moment. My gut feeling is it's not as bad as the United States, but it could still be an issue. But
certainly has pushed the premiums paid,
Yeah, well, that's
especially by obstetricians.
that's not because of the cost of investigation. It's because of the cost of the litigation, and the premiums have gone up because there've been some really significant awards to patients or to patients who've had adverse outcomes, whether or not those adverse outcomes are really attributable to the care that was actually provided. Obviously, there's been some work done here at the University of Melbourne which suggests that sort of moving towards more of a no-fault system would save a hell of a lot of money in that area.
Any more questions?
Yes, why is the price of prescription drugs in Chemist Warehouse much cheaper than in local?
Why is the cost of drugs at Chemist Warehouse so much cheaper than in your local chemist shop? Well, the short answer is the Chemist Warehouse is a chain, so you get good deals from the suppliers. But so too, most of your little chemist shop is also part of a chain often, a buying collective, and they might have a different sort of name, but they're also, so they can get some of those. But one of the big differences is Chemist Warehouse passes on a lot of the discounts they get from the manufacturers to the consumer, and so they're relying on high volume as one of the reasons that they can make a profit, whereas the local chemist shop isn't under as much pressure to pass on those discounts.
Are they getting discounts on ethical stuff?
Probably not on the non-generic. The question was, are they getting discounts on the non-generic drugs? And the answer is probably not. When we compare prices in Australia with prices overseas, the huge difference in prices were on generics, and the price difference on non-generic on drugs still covered by patent was trivially small, because a single international company is doing it, and so there was no difference. So they're probably not getting discounts on the drugs still covered by patents. But they might get a volume discount, but they're not going to get a steep discount. Sorry.
Sorry, the pharmacists, they would make, the government's made a deal with Pfizer to buy a drug for $30, whatever else it is. The pharmacist who sells that to you make a commission on it.
Yes.
Do they make a commission the same or greater if it's a generic drug?
The commission is based on the
profit. Try to sell you some other.
Yeah, there's a question about how pharmacists are remunerated. The commission they get is based on the government official price. So if they get something, if they can negotiate a price lower than that, they still get a commission based on the government's official price. So they might say, okay, they might have two brands on their shelf, and one they were able to buy for $2 and one they were able to buy for $10. And if they can persuade you to get the $2 one, they can charge whatever they like.
A lot of people here will pay only $6 or something because they go to their Lipitor.
Yeah.
But the pharmacist says, we have something better than Lipitor, it's a generic, it's cheaper, and all the rest, it still costs you $6.
Yes. They get all the saving. But yes, they get the same amount for dispensing a generic as they get.
But they charge you more than $6
Yes.
if you don't choose their cheaper brand.
Yes. No, they can only charge you a maximum of $6. For some of them, there's a so-called brand premium, but for most drugs, they can only charge you the $6. If you're a pension or healthcare card holder, it's $6.10 or something, $6.90, $5.90, $5.90.
I'm curious as to the huge variation in cost of the hospital level run by robots, which is 10 times the cost of the old-fashioned surgery, and yet the stay in the hospital, the old-fashioned style, is vastly longer. Surely pay hospital to use the robots more?
The economics of robots is very, very complicated. So the question was about, the robot. If you have a prostate you stay in hospital your hospital stay is much shorter because essentially the incision is much smaller. So the economics of robots is very complex. They're very, very expensive to buy, and they're very expensive to use because they have I won't say disposable cutting, but scalpel sort of thing, but they're actually expensive to use as well. But they do reduce length of stay. So when I was in Queensland, I organised the first public sector robot to be installed at the Royal Brisbane Hospital, partly because when you did we were able to get someone else, we got the Commonwealth to fund the capital costs, so it changed the economics of it. But it also helps with waiting lists, and we're trying to get waiting lists down because you reduce the length of stay and so on. So it actually became a worthwhile economic and political thing to do, but because of the high capital cost, it really gets complex in that.
Thank you.
One last one.
One thing that struck me in your presentation of the box plots of the price per hip replacement graphs was the lowest hospitals, or the cheapest hospitals, or the cheapest states had quite a narrow range of costs. And it struck me that the hospitals or the states that had the highest costs had such a wide range. What drives that in-hospital distribution cost?
Well, I think we haven't analysed that, but I think it's due to there's been a movement sweeping the world about care paths, where you actually say, if we're going to have a hip replacement, this is what we're going to do. Boom, 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 boom. And it's gone further in some countries. They say we're going to concentrate all our hip replacements in one hospital or one ward at one hospital. So the nursing staff, the physios and so on, really become experts in hip replacements and know what they're doing and know what they're doing all the time. My mother was admitted to hospital recently with needing a bowel cancer operation, and because of bed pressure and so on, she was admitted to a medical ward. So the nurses basically didn't know how to dress surgical wounds or anything like that. So this whole issue of standardisation and so on is really one of the movements that's going across the world. And it also, these things become evidence-based. We know what works, and that's what we're going to do in this hospital. So reducing the autonomy of individual surgeons to do things in particular ways, individual physios, individual nursing units do things, and actually saying this is what works and this is what we're going to do. And I think that's what needs to be happening. And when I first got involved in these areas, everybody said, the doctors say, oh, that's cookbook medicine. Well, actually, it's probably not a bad thing if you start off by doing things according to a recipe. And how many of us in this room have copied recipes off the internet or cookbooks because we think, yeah, this is a good place to start. I won the Beauview Parade MasterChef competition a couple of weeks ago.
I've tasted his pate.
Tasted my pate, but I copied George Columbaris' Cypriot grain salad, and it was the winner. So I think there's actually nothing wrong with cookbooks.
I have a final question. What's the name of the report that you've just done, and what can we do to help in terms of making these changes go ahead? We've got a collegium.
Yeah, so the report we just released yesterday or the day before was called Access All Areas, which was about workforce issues in rural and remote Australia. And basically we're arguing if you live in very remote Australia, on the basis of current policies, it will take 65 years for people in remote Australia to have the same access as people in the cities. And we're suggesting this is a tad too long. And we've made a whole series of recommendations about that. So specifically, Kerry, from your perspective, since you're a millionaire, if you could donate some money to me, I'll give you my bank account details. But basically what we'd ask you to do is be aware, to think about these issues, to think about when you hear stories about health costs out of control, think about, well, hang on, is it about better management, better dealing with efficiency, innovative solutions, or just more of the same, what we've done in the 19th century is good for the 21st? That's what we prefer you not to say. Thank you very much.